Managing Director at RFH Healthcare. And Dr. for starters, being a doctor and seeing this particular situation, matters to do with mental health, payment, even before we move into investment, financial investment into the sector, investment in human resource, how critical is that, and where are we seeing these developments?
Human resources for health is one of the key pillars for health, and that if you don't have them, then you actually know there's no health that exists. We can invest in the big buildings and the big equipments, but without the human resources, then there's nothing we are doing. So it is one key sector of health that we cannot ignore completely. Otherwise, we'll not be honest with ourselves.
Definitely.
I've gone through the whole chain. I've been a medical intern. I know what they go through. And it's sad in this day and times to see these stories. I think there's a second person committing suicide, and that calls for something that needs to be looked into. Definitely, yes.
Definitely. Yeah. And now moving into the health sector, because you guys are undergoing a lot of changes, and Kenyans are involved because health is a critical part of each and every single person. This whole transition, first of all, into SHIF from NHIF, as somebody who runs hospitals. What was not working at NHIF that SHIF is introducing?
Of course, every system must have transitions, and be as it may be, the government had reasons why they needed to bring SHIF. There are very good things in SHIF and SHA, and I'll be honest with you. We've had a lot of challenges with NHIF. We had a working system, but there were things administratively that were not working that I think they have introduced.
Okay.
Before that, if you're going to attain universal healthcare, any healthcare facility for a social healthcare scheme should be able to attain and be part of that healthcare scheme. Previously, for any hospital to be opened, before you are NHIF accredited, you could have waited for almost a year. And that means there are areas in this country that did not have that benefit. Today, it is a seamlessly IT developed system that you load your licenses and you can get accredited within 30 minutes. And so give credit where it's due. There's been a lot of human resource, actual human beings involved in the processes. And so, of course, when you remove human interface, then of course you reduce bureaucracies, and those are some of the benefits that SHA has introduced in the SHIF. Of course, we have the two schemes, that is the emergency healthcare fund and chronic healthcare fund that we didn't have. I mean, I'll tell you, for example, in my facility last year alone, we wrote off about 30 million Kenyan shillings. Because there are Kenyans who come in emergency situation, and these are costs that we actually incur, but nobody pays for them. So either the hospital absorbs them, or basically you just have to absorb them. Right now, there's a fund that has been dedicated to emergency healthcare and chronic illness. Whether is it adequate or not, I'm not sure. Time will tell. But at least is a step in the right direction. So with that, I can give credit to them. The problem, and also it's good to speak the truth as is, was the process in which the transition was taken through. I keep saying that, of course, there are two ways we could have done it. If you have a 13-year-old child who's just getting into adolescence, and this child starts drinking or starts doing weird things, you don't kill that child to give birth to another child, right? Because you need 9 months to carry the pregnancy and then deliver the child. But here we are. So we have already transitioned. How do we ensure that this transition does not affect very many people? We've had challenges the past 1 month or two, but I think it's stabilizing. I believe it's just that people need to build and gain the confidence. The problem we are dealing with now is not that the system is bad. The problem we are dealing with is because people have lost confidence in the process. So what we need to do is build confidence in the process. That is what is lacking. The other thing that raised a lot of questions was Kenyans would be capitated to any hospital that was NHIF accredited. Then, of course, we removed outpatient services from level 4 upwards to level 2 and 3. And so there are hospitals that Kenyans perceive to be hospitals, and the others they perceive to be clinics. So the health-seeking behavior of Kenyans is that they want to get healthcare in a one-stop shop. not a place where I'll come and then when I need an x-ray, you transfer me or refer me to another facility. And so when most of those hospitals were not in that list, that's where Kenyans were getting complaints from. But I saw an effort towards that, and a letter was written to hospital owners that level 4 facilities who are interested in giving outpatient services can seek that, can show that interest, and they'll be included in the list for capitation.
Okay.
Of course, there are questions and issues which have been raised about the rates. I don't want to speak for the people running the project or the program, but I want to believe initially probably they were not sure of how much they'll raise, and so when they were losing at those figures, they were looking at best case scenario. Fact also, NHIF was also not very sustainable. That is a fact that Kenyans have to know. Because if you're running as an insurance scheme, you look at your premiums vis-a-vis your claims. So what's your premium claim ratios and what are your loss ratios? So if your loss ratios are too high, then you're running a scheme that will collapse at some point. Okay. And so the claims were higher than the premiums we were collecting. Okay. The people who are benefiting more from so we had an adverse selection mechanism whereby you will come and pay when you know I will need the service in 2 months. So for example, I'll pay 6,000, but I need a surgery for 150,000. So when I consume that surgery for 150,000, how many people have I consumed their premiums? Do the maths. Yes. So you have a fund that at some point will either be in loss or will go through bankruptcy or liquidation.
Definitely.
And so I think the actuaries who are working the rates for the current scheme started from the bare minimum situation. So I want to believe, and I hope that is what they are working towards, that they will start reviewing these rates. For example, Kenyans have made noise about the dental and the optical. I hope they'll review the rates as time goes and look at how much they've collected. I've just heard in the news that they collected 9 billion. I didn't know that. But that's a huge fund. So that means we're looking about 100 and something billion in a year. I believe that is more than enough to cover Kenyans, because I think the highest claims ever claimed from NHIF in 1 year was about 30-40 billion. So means we have a big headroom. So they need to go back to the drawing board, review the rates that they are going to reimburse, because cost of healthcare is cost of healthcare. We cannot hide our hands under the sun. So if the cost of a cesarean section is 40,000, it is 40,000. If you pay someone 10,000, it means there's somebody somewhere who's paying this 30,000.
Yes.
And that is a question, who's paying this 30,000. So we can't lie to ourselves. There are actual market rates that we must go with.
Okay.
Yes.
Definitely. And talking about the market rates, because the goal for the common person is to get healthcare at an affordable rate. I know we talk about affordable housing, but affordable healthcare is quite critical. How do we marry investment in the sector and lowering the cost or raising affordability of healthcare in the country?
The countries that have done it successfully have done two things. The role of a government is to take care of the health of its citizens, but also look at healthcare as a revenue generating mechanism. And that's one thing I keep pushing for. How do we position Kenya as a health tourism destination so that it just doesn't become a consumer, but also a generator of revenue? So for example, how do we increase investments in health? Today, people are going to India for healthcare. So today, healthcare for India is a revenue generator and not a cost consumer. So how do we position Kenya as a health tourism destination for sub-Saharan Africa, for example? How do we bring investments that are not available in our neighboring countries so that our neighbors can come to Kenya and pay us in dollars? And so that becomes a revenue, so that when healthcare institutions are paying tax to the government, they're generating employment opportunities to Kenyans. And health sector is the only sector that employs all cadres of people, from drivers to hospitality people, to masons, to biomedical engineers, to doctors. It is a multi-sectorial industry.
Okay.
Yes, so if you invest in health sector, then you're actually investing in the entire economy and its entire ecosystem for the economy.
So that positioning you're talking about, even as we wrap this up, how do we, is it a policy intervention level? Is it a quality standardization level that to ensure we place our healthcare at that particular level?
Quality, Kenya has the best doctors in the sub-Saharan Africa. I can say that confidently. In terms of our expertise, we stand amongst our peers and higher than our peers. It's a policy level, first of all. We need to relook at some of these taxation regimes that touch into health sector inputs. Sometimes you find, for example, today, people are complaining about dialysis. The filters of a dialysis have been placed like any industrial filter. How do we remove these inputs in health sector? So because as long as the inputs of health sector are higher, the cost of service also goes higher, right? Yes. Number two, how do we produce many human resources so that also the cost of labor can come down, right? It is sad that today it is cheaper to bring a doctor from Egypt, for example, or Turkey, than to pay some cadres in Kenyan doctors' system. Okay. I'm not saying we should pay our doctors badly, but it's an issue of what can the market afford and what do they deserve? Okay. And how do we get a midpoint so that no party feels not satisfied? Then, of course, now we look at generally the other inputs, so taxation of healthcare inputs, that becomes at a policy level, and also just opening the space for players to come in and invest so that the government comes and plays at a policy level, and then lets people compete on quality and cost. Definitely. That is the only way you bring the price down.
Definitely. Yeah. Government, make sure that you're providing oversight and enabling environment, and let people compete on quality and cost. Yes. We couldn't finish at a better note. Thank you very much, Dr. Terry.
Thank you very much.
All right, Dr. Maxwell Okoth is the Group MD, RFH Healthcare, and he says that a lot is going on in the sector, but there is room for improvement, and one of them is to create an enabling environment, shifting policy to make sure that at least the cost is coming down. Some of these interventions are critical to make sure that our healthcare system is working, and at this particular moment is where we put a full stop to business today. Thank you very much for joining with us. I'm Nakib Kimboy. Up next, you have Mbiwa Kitian. Stay tuned and bye-bye. That is our doctor. That is nice.